Hello, this is the second video on male reproductive anatomy and physiology. Here we're going to just do a quick overview of the steroid physiology of testosterone and some of the related hormones. Look at the sort of how androgens like testosterone are circulated in the blood, how they're metabolized. I'll say a bit about androgen receptors, and then finally end with the actions of testosterone in males as well as females. So the primary sex steroids in males that we need to focus on are, of course, testosterone would be one, as well as dihydrotestosterone, which is going to be, again, a more active form of testosterone. And then males also release androstenedione as another androgen, as well as DHEA, and then estradiol. Of the three, really, testosterone, dihydrotestosterone, estradiol are going to be the three we're going to focus on. The enzyme 5-alpha reductase, remember, is what converts testosterone into dihydrotestosterone. We went over that in the last video. And the 5-alpha reductase is found really highly concentrated in the skin, in sebaceous glands, for example, in hair follicles, in the testes, the prostate, and in adipose tissue. And it converts about 5 to 10% of the peripheral testosterone in a male into dihydrotestosterone. There are different genetic polymorphisms of this enzyme, making it more or less active. We're not sure clinically. Usually that doesn't have much of a significance. So that's one way, in addition to testosterone, we can have dihydrotestosterone working in the body. And dihydrotestosterone really has a stronger effect than testosterone. It's going to essentially, in the skin and sebaceous glands, cause increased sebum, so that will lead to increased acne. In the hair follicles, it can actually cause a sort of a slowing down of the growth of new hair follicles, and that can lead to androgenic alopecia. In the testes, and especially the prostate, it can cause overgrowth of tissue, and that might be connected with BPH, benign prostatic hyperplasia. There's a class of medications known as 5-alpha reductase inhibitors. Proscar is one example of those. We have natural inhibitors like saw palmetto, zinc. All these things can slow down the activity of 5-alpha reductase. I'll come back to that in the pathology section to tell you about how useful those are and whether or not we should be thinking about prescribing those. So that's one action, is through testosterone to dihydrotestosterone. Testosterone can also be converted into estrogen, estradiol, and that is via aromatase, which is a CYP450 enzyme. 5-alpha reductase is not a CYP450, but aromatase is, and this converts androgens to estrogens, and specifically converts testosterone to estradiol, or androstenedione can be aromatized to estrone, E1. And this enzyme is found in the smooth endoplasmic reticulum of cells, and it's found in many tissues like the brain and bone, but primarily in men, it's in the adipose. And so the more adipose a male has, the more testosterone he'll most likely aromatize to estrogen, which is not so good. And this is why testosterone supplementation in men becomes complex, because if they have a lot of aromatase, they're just going to convert all that into estrogen, which is not so good. All right, so we can look at testosterone, which is secreted about 5 to 7 milligrams a day in a younger man, maybe before the age of 50, 55. It's going to have direct effects on the tissues via androgen receptors. About 5 to 10% of it will be converted by 5-alpha reductase to dihydrotestosterone. That also can bind to the androgen receptor, but with greater affinity. And then a little bit of it will be converted via estradiol, by aromatase to estradiol, and that will work via the estrogen receptor in males, which are just found throughout the body as well. So these are the three ways that testosterone can really work in a man. So if we look at the testes, they are going to secrete via the Leydig cells testosterone, and that's where the majority of testosterone in males comes from, is the Leydig cells. The rest of it, about 5%, comes from the adrenals. So the adrenals in males do produce testosterone, a small amount of it, usually from the DHEA pool that comes from the adrenals. Again, the secretion in adults is about 5 to 7 milligrams a day. That's going to drop down to about 4 milligrams a day by the age of 70, and testosterone works directly via the androgen receptor. dihydrotestosterone, again, more active than testosterone, and we see increased DHT in acne, scalp hair loss, and BPH. Those are the three primary conditions we usually think about with dihydrotestosterone. And then DHT binds to the androgen receptor as well, but again with higher affinity. And then estradiol, also produced in the testes, but again from peripheral conversion, which I'll cover here, is going to bind to estrogen receptors. And estrogen receptors are complicated because there's actually two classes of them, alpha and beta, and we'll go over that in detail, especially in the female reproductive physiology. The adrenals secrete a little testosterone again, and that's again through DHEA, which can be converted to androstenedione and then testosterone, and that provides about 5% of the peripheral testosterone in males. And then through peripheral conversion, again, we can create dihydrotestosterone in these different tissues. And then via aromatase, we can convert testosterone into estradiol or androstenedione into estrone, especially in adipose tissue. But aromatase, again, is found in the Sertoli cells, found in the liver, the skin, central nervous system. But the conversion is very small, so typically converts about 0.1% of the peripheral testosterone into estradiol. Remember, 5 to 10% of peripheral testosterone is converted to dihydrotestosterone. So this is a very small amount, although this, again, the levels will increase of aromatase with age in men. In fact, in a 65, 70-year-old man, especially if he has a lot of adiposity, his level of estrogens can actually approach the female levels of estrogens during the reproductive follicular phase. So you get very high amounts of estrogen. We think in men, one of the things that we see metabolically is it tends to increase abdominal fat deposition. A decreased testosterone to estrogen ratio, which would indicate either less testosterone or more estradiol, would also lead to gynecomastia, male breast enlargement. All right, so that is the peripheral conversion. So essentially, testosterone and these hormones can come from the testes, from the adrenals, or from peripheral conversion. Just want to review, we already looked at this in the adrenal physiology section, but the steps of testicular steroidal genesis again occur in the Leydig cells, for example, the primary source in the testes, and this is stimulated by LH. And the first step is conversion of cholesterol into pregnenolone. That's going to occur in the mitochondria in the Leydig cells. The pregnenolone will then diffuse into the cytoplasm. And there's two different pathways that can be used to convert pregnenolone into testosterone. They're either the A4 or the A5 pathway. In humans, the A5 pathway is the most predominant, and that's the one that's actually demonstrated here with the darker lines. So here we have pregnenolone, and the darker lines here, we get 17 alpha hydroxypregnenolone. That converts into DHEA, and then that converts directly into androstenedione, and then into testosterone. And then either via 5-alpha reductase into dihydrotestosterone, or into by aromatase into estradiol. And again, androstenedione can be converted into estrone. So that is the A5 pathway. That's the most predominant pathway in humans. Okay, so that's, in a nutshell, the processes involved with testosterone. Now, once testosterone is secreted, it has to be bound in the blood by a carrier protein to carry it, and that is sex hormone binding globulin. And that's, again, made in the liver. About 60% of testosterone is bound to sex hormone binding globulin, just about 38% to albumin. So that leaves about 1 to 2% free or unbound, which can then go directly into the tissues. Sex hormone binding globulin levels will be increased by estrogen and any sort of selective estrogen receptor modulator, if they're taking medications for that. Increased thyroid hormones will also increase, like in hyperthyroidism. And this would result in more testosterone being bound up to sex hormone binding globulin, and that can cause potentially less testosterone to be available to the tissues. The different drugs like anticonvulsants, phenytoin is a good example, and then liver cirrhosis, which tends to make decrease the clearance of estrogen, allowing estrogen to build up, but also raise sex hormone binding globulin. Levels will be decreased with exogenous androgens or glucocorticoids or progestins, decrease thyroid, increase insulin resistance, and increase growth hormone. So in the old days, when we used to test testosterone, we would get a total testosterone, and we'd have to measure sex hormone binding globulin to be sure that that wasn't interfering with our ability to get free testosterone into the tissues. Now we have a direct free testosterone test, so we don't have to really think about this as much with these different factors. A couple of little diagrams which I think can help summarize this would be, again, if we look at the testosterone in the blood, we have unbound, the albumin portion, sex hormone binding globulin portion. We're going to get conversion of about 5-10% of that into dihydrotestosterone. We're going to get testosterone direct actions in the tissues, and then via aromatase, 0.1 to 0.3% converted into estradiol, and that'll have other effects as well. And then eventually testosterone will be metabolized, and we'll talk about that here in just a second. This picture is interesting, or this diagram, this chart, looking at ages, total testosterone, free testosterone, and sex hormone binding globulin levels. So notice in a 25, 34-year-old, total testosterone of 617 on average nanograms per deciliter, free of 12.3 nanograms per deciliter, and we have fairly low sex hormone binding globulin levels. By the time you get to 75, 85, our testosterone levels have dropped to 471 for total. Free is only half of what it was between 25 and 34, and then sex hormone binding globulin levels go up, so we're binding up more of that testosterone, not allowing it to enter into the tissues. So that's a typical progression we see with free and sex hormone binding globulin with age. The primary site of metabolism of androgens is in the liver, and that's going to happen for both testosterone and dihydrotestosterone. And that's going to happen through different pathways. There can be direct conjugation with glucuronic acid or sulfate, and then those metabolites are excreted in the bile of the urine. And that accounts for about 50% of the metabolism. About 40% go through what's called the 17 Ketosteroid Pathway. And there are 5 alpha and 5 beta reductases, which form different metabolites, which are then glucuronidated and sulfated. And they're excreted in the urine as 17 ketosteroids. So some of the labs out there doing urine tests for androgens are measuring the ketosteroids as a marker for androgen levels in the blood. And then about 10% go through phase 1, oxidation hydroxylation, and they can be excreted directly or further conjugated with the glucuronic acid or sulfate. So increasing sulfation, for example, would increase clearance of testosterone through the liver. So testosterone, dihydrotestosterone, androstenedione can work on cells via 2 different pathways. One is, I'll start with the genomic pathway. This is the classical pathway. And this has a fairly slow action, takes a couple of days for this to really activate. And that's where the androgen essentially is going to enter into, diffuse across the cell membrane. It's going to bind to a inactive androgen receptor, usually in the cytoplasm. Usually that receptor is blocked by heat shock proteins that have to be removed. And then it's going to form usually a homodimer with another androgen receptor, and that's going to be translocated to the nucleus, and that's going to stimulate gene transcription and then eventually translation into anabolic proteins. That's the genomic pathway. The non-genomic is a rapid-acting pathway, and it's fairly newly discovered, so we don't know a lot about it. But this is where the androgen binds to a cell surface androgen receptor, and that is going to upregulate various protein kinases. Remember, a protein kinase phosphorylates a protein, and that's going to activate the different effects in the cell. So it's going to stimulate via intracellular signaling different effects on increasing androgenic activity within that cell. This non-genomic pathway has been found in the prostate, the testes, breast tissue, and skeletal muscle. So those are the 2 primary pathways. Again, the classical pathway is what we usually think about with the androgen receptor working intracellularly, but there is this cell surface androgen receptor which has non-genomic actions as well. Finally, what are the effects of testosterone and other androgens in males? Let's focus on that here first. In general, we can think of them as anabolic steroids. They're increasing protein synthesis and growth of any tissues that have androgen receptors. So testosterone specifically has an anabolic effect. It's going to increase muscle mass and strength. It's going to increase bone density and strength and stimulate linear bone growth and maturation. It also has androgenic or virilizing effects, and that is going to stimulate the maturation of sex organs like the penis and the scrotum, deepening of the voice, increase of facial and axillary and pubic hair growth. And then both DHT and estradiol are going to work alongside the testosterone to promote these actions. So again, testosterone, DHT, estradiol are the three ways in which androgens really work within the body. So we usually divide the discussion of sex hormone effects into primary and secondary sex hormone effects. So in terms of testosterone, it helps develop what we call the primary sex characteristics in the fetus and in early life. So in fetal life, between 4 and 6 weeks gestation, the levels of testosterone really activate genital virilization. So it activates development of the penis, the scrotum, the prostate, and the seminal vesicle development. And both testosterone works alongside with dihydrotestosterone here to activate those effects. In the second trimester, this is really where sex formation occurs, and that promotes the development of what's called the Wolffian duct, which is the precursor to the male reproductive system, and degeneration of the Mullerian duct, which is the precursor for the female reproductive system. So that's going to all begin in the second trimester. And then this is where also in the brain, what we call masculine behavior circuits begin to develop. And usually that's under the influence or stimulated by estradiol levels as they elevate via aromatization of testosterone in the brain. That's what stimulates those neural circuits to be laid down. In early infancy, testosterone levels rise in the first few weeks after birth. Remember in the last video I discussed that with the fetal Leydig cells. And then this will remain elevated for a few months and then they decline and will barely detect testosterone by 4 to 7 months. And the function we think is, again, to create a pool of estradiol, which is going to help with development of the brain. In females, again, as I mentioned in the last video, estradiol is actually blocked by alpha-fetoprotein, and so it does not enter the brain. So a female brain develops without the influence of estrogen. Male brains develop with estrogen. Before puberties, the androgens start to rise, and that starts giving virilizing effects. And we start seeing things like adult-type body odor, increased oiliness of the skin and hair, acne, appearance of pubic hair, axillary and armpit hair. There's a growth spurt with accelerated bone maturation, and then facial hair. And then at puberty, in adolescence, there's a lot of complex interactions that happen with androgens, growth hormone, nutrition, different genetic factors. Essentially, growth hormone is going to cause the increase of long bone growth and length. The androgens will then stimulate the spermatogenic tissues like testes, epididymis, vas deferens, seminal vesicles, penis, and scrotum. They will stimulate muscle hypertrophy, increasing muscle protein along with growth hormone. Increase the development of the larynx, so the deepening of the voice. And then via estradiol, via aromatization, that's going to accelerate the closure of the epiphyseal plate. Usually that's going to happen after it occurs in females, which is why boys tend to grow a little bit taller, but also they keep growing longer after the epiphyseal plates have closed, typically in females. And it's going to also, in puberty, testosterone and androgens will decrease visceral fat. In adults, testosterone still plays a role in the primary sex characteristics for normal sperm development, and they'll also maintain muscle growth and bone density. So those are primary sex characteristics. Secondary sex characteristics on hair, and this is primarily through dihydrotestosterone. We can actually classify hair based on its sensitivity to androgens. So non-sexual hair would be things like eyebrows and extremities. Remember, eyebrows have an influence by thyroid. So low thyroid, we start to see eyebrow thinning or loss of eyebrow hair on the lateral edges. There's ambisexual hair, which is in the axilla. and they're responsive to the low levels of androgens. And then sexual hair is facial hair, chest hair, and hair in the upper pubic triangle. Hair follicles metabolize testosterone to dihydrotestosterone or androstenedione. And during puberty, that will usually promote hair growth, but unfortunately can also lead to balding, and that's the so-called androgenic alopecia. So it depends on a lot of factors genetically, but also the levels of testosterone, the levels of dihydrotestosterone, and finally the amount of androgen receptors in those hair follicles. In females, elevated androgens will lead to hirsutism and male pattern facial hair growth. So that's obviously something we're going to see like in PCOS, polycystic ovarian syndrome, with elevated androgens. Those would be some of the early clinical presentations. In the sebaceous glands, the androgens will increase, especially dihydrotestosterone, sebum production. And this is the main driver of acne and even rosacea. So I'm always looking in those patients at their androgen levels, but also we know that insulin can actually upregulate the amount of androgen receptors in the sebaceous glands. So people with hyperinsulinemia, prediabetes, are going to be more sensitive to androgens in those cases. Estrogens inhibit the sebaceous glands. So estrogen actually inhibits acne formation, but androgens stimulate it. So we can think of acne really as, again, either high androgens or just increased sensitivity of sebaceous glands to the androgens, usually by having more androgen receptors around. Again, insulin can help sensitize that. In the brain, androgens have neurosteroid activity. So one of the effects would be on GABA to actually make the GABA receptor more sensitive. But the primary effect is to increase dopamine activity. So we can think of the androgens like testosterone as really upregulating dopamine and improving the dopaminergic signaling. So that's, I think, an interesting connection between neurotransmitters and hormones. Androgens upregulate dopamine. Estrogens we'll see actually upregulate serotonin, and progesterone upregulates GABA primarily. Now, in males, testosterone also upregulates GABA a bit, but an easy way to think of that is, again, dopamine, testosterone, serotonin, estrogen, GABA, progesterone. In terms of activity on mood and behavior, testosterone usually increases sexual arousal activity. We think it also increases aggressiveness and adult criminality, but studies that have looked at this in detail have actually found a pretty minimal effect of testosterone. There's a lot of other factors that go into that. We think testosterone increases competitive behavior and potentially antisocial behavior and alcoholism. But there we might think that even low testosterone can cause that because that would deplete dopamine or cause less dopamine around. And so people are doing things like seeking addictive behaviors to increase their dopamine signaling. Testosterone can help downregulate the HPA axis. So males that secrete lots of testosterone tend not to be as affected by stressors versus, in packs of animals, the so-called beta male. Beta animals are actually going to be more affected by stressors, and they actually secrete less testosterone, interestingly. Now, cardiometabolic effects are complicated. The effects really depend on the levels of testosterone. So physiologic levels of testosterone actually we think are very cardioprotective. So they improve endothelial function, and that decreases cardiovascular risk. So we see a decrease in ischemic heart disease, cardiac heart failure, decrease in atherosclerosis partly by decreasing the cytokines we know that help drive atherosclerosis, increasing HDL, and decreasing insulin resistance, so improving insulin sensitivity and decreasing the incidence of type 2 diabetes. So those are at physiologic levels. Unfortunately, we hear a lot in the press about how bad testosterone is for the heart and blood vessels, and that's usually based on looking at high dose or super physiologic levels. So people supplementing hormones, for example, for weightlifting, things like that, might get super physiologic levels, and there we see an increase in cardiovascular risk, increase in LDL, and increase even in MI. One other area I should mention is Afib, atrial fibrillation. We find a lot of older men with Afib actually have very low testosterone, and testosterone replacement to physiologic levels actually reduces their atrial fibrillation amounts. So that's one good example of how the heart muscle is really dependent on all these hormonal influences for proper functioning. So that's one big one with normal testosterone. Now, clinically, and I'll talk about this more in the pathology section, the way to really work with testosterone in older men is not to supplement testosterone. That's really for more extreme cases, but rather to try to, for example, increase DHEA production from the adrenals, and that could be done through different herbal routes. Or there are a whole set of herbs known as phytoandrogens, which can increase either testosterone production or the number of androgen receptors or decrease sex hormone binding globulin. All of those effects would increase the testosterone activity in the body. Nutrition, exercise, diet, good sleep, all of those also will dramatically improve testosterone activity. So really the best way to deal with testosterone in most cases is not to supplement it, but rather to increase the body's secretion of it by giving the right nutrients and the right hormonal signaling to the glands to do that. So that is the cardiometabolic effects, not quite as simple that way. On the blood, testosterone will increase the number of red cells in the mass, so increasing hematocrit basically, and that's by increasing the erythropoietin from the kidneys. Now, DHEA and androstenedione and testosterone all do that. So testosterone supplementation usually increases red cell mass, would potentially treat anemia, prevent anemia. And in fact, some of the beneficial effects of testosterone supplementation in older men is correction of microcytic or normocytic anemia when we've ruled out any sort of bleed or cancer, sort of an idiopathic anemia. We find it's from low androgens. And we think the same thing happens in females. Low androgens in females, especially DHEA, might lead to increased anemia, especially microcytic or normocytic anemia. Unfortunately, testosterone can also increase platelet aggregation. Again, we see that more in the supraphysiologic levels by increasing thromboxane A2. So that would be a negative effect there. So lots of effects of testosterone in males. And again, they're not all mediated by testosterone alone, but also by dihydrotestosterone and by estradiol in different tissues. Now, I just want to say a final thing here about testosterone and androgen effects in females. This is more difficult to study because a lot of the androgens are aromatized in females to estrogen, so it's hard to say what is actually from estrogen or testosterone, etc. But the majority of androgens in females are produced in the adrenals, interestingly, and especially after menopause, and that's primarily via DHEA and DHEA sulfate, and then the rest is from the ovaries. The circulating levels are far less than in males, and the levels also decline with age, the androgens. But we have found androgen receptors in nearly all tissues in the female body. So we know that androgens are having an effect in females. Some of the direct effects are on the sex organs to increase the size of the clitoris and to increase genital sexual arousal. In fact, that's the one approved use of testosterone by the FDA in females is to treat called genital arousal disorder. So that is one thing we know that androgens can do. And generally potentially to stimulate and maintain libido in females as well. That can be an effect. Still in the research is the effect of androgens at increasing muscle and bone mass, protecting again against anemia, decreasing cardiovascular risk, at least to the physiologic levels, decreasing risk of depression, as well as metabolic syndrome. So I think this diagram over here is interesting, looking at estrogen levels, estradiol with age, and here is testosterone levels in females, much higher. And again, most of it is being aromatized, or a lot of it's being aromatized into estrogens. But testosterone, for one, is definitely having direct effects via the androgen receptor in these different tissues. So this is an area of active research, and this is where there's debate. For example, in menopause, the question is, do we replace, in addition, if you're doing hormone replacement therapy, which we'll get into later, if that's necessary, do we replace estrogen, progesterone, and potentially testosterone as well? We usually think of androgens in females in a negative sense, and that's with elevated androgens, and that happens very clearly in PCOS. And again, there's really two types of PCOS. One would be the adrenal type, about 30%, where there's an increased secretion of DHEA, usually from increased release of ACTH along with cortisol with stress. The other would be the ovarian type, about 70%, with increased testosterone and more insulin resistance. So we get ovarian secretion of androgens in those cases. But there we're going to see different types of obesity, especially with the second type here. Hirsutism, acne, menstrual irregularities like oligomenorrhea, menstrual periods over 35 days, or the time between menses over 35 days, reduced libido with too much androgen, and then edema from that as well. So those would be some of the clinical manifestation of high androgens. We usually think that testosterone therapy of any sort, like giving testosterone replacement, is contraindicated in breast and uterine cancers because those often have receptors for estrogen and or progesterone, and that testosterone can be aromatized right into the estrogens, and that can drive the cancer growth. That said, some of the new research actually finds that testosterone along with other hormones can actually be protective in those cases. So this is an area where you hear a lot of contradictory information, and I'm sorry I can't be more clear on that because the research is still unfolding. But understanding a little bit about where the androgen receptors are, what they do in the different tissues, and the effects of different hormones on them can be one way of teasing through all of the ambiguity. Okay, so that wraps it up for the male reproductive anatomy and physiology sections, just ending here with a little discussion of testosterone in females. We'll follow these videos up with videos on pathology of the male reproductive system, and especially focusing on endocrine pathologies.